So I know we're live now, but I'm just going to wait and see till we get a few more people in, because I know there's a bunch of other sessions going on too. So wait for a few more participants before we talk. Maybe I'll wait till we get to about 20 because they're coming in pretty quick. Okay, so at least let's get started with some of our introductions. So welcome everybody who's joining us. So this is the education session that's Ask the Speakers. So it's a question and answer period for those of us that gave the live presentations. So I will introduce everyone in the panel this evening. So I'm Mary Helen Mahoney. I'm a plastic surgeon in Toronto at North York General Hospital. I'm the reconstructive lead of our breast reconstruction program as it relates to our cancer care program, which is nationally accredited, and I'm a lecturer in the Department of Surgery at the University of Toronto. We also have with us Dr. Catherine Isaac. She's from Vancouver, British Columbia. She is a plastic and reconstructive surgeon and assistant professor at the University of British Columbia and the Clugston Chair of Breast Reconstruction Research. And her research is focused in public health and policy with a crossover into digital health and data science. So welcome, Dr. Isaac. We also have Dr. Tony Zong from Toronto. She's an associate professor in the Department of Surgery at U of T and the clinical and research director of the UHN Breast Reconstruction Program. She's also the Belinda Stronach Chair of the UHN Breast Reconstruction Surgery. So welcome, Dr. Zong. From Kingston, we have Dr. Glika Martu, who's a plastic surgeon specializing in breast reconstruction, and she's also an assistant professor at Queen's School of Medicine. And we are fortunate to have Dr. Mitchell Brown join us tonight. He's a plastic surgeon at Women's College Hospital in Toronto and a professor in the Department of Surgery at U of T. He has a clinical focus in aesthetic and reconstructive breast surgery, and he actually founded Broad back in 2011. And this was founded to address the need for improved education, access, and awareness for women surrounding breast reconstruction after mastectomy. So welcome, Dr. Brown, as well. So we have some questions that are coming in live, and if we don't fill up all of our time with some of these live ones tonight, there were some early submission of questions as well that relate to a lot of our talks. So I think we'll address as many of those as we can as well. So the first question that's been submitted is, can you talk more about the difference between above and below the muscle implants? Is one safer or does it lead to better results aesthetically? I don't mind answering this since I talked about this briefly in my talk. So I didn't go into this too much because it's sort of a newer area in breast reconstruction, whether we place implants above or below the muscle, because there's definitely some benefits to both. So traditionally we did do below the muscle, but definitely there's a trend more to above the muscle. And that's because of the part where we leave the muscle out of the equation. So we no longer will have a muscle contracting on top of an implant, which can be ideal for many women. The issue is if you place an implant above the muscle, as was shown in some photos in some of the talks, you do get more wrinkling, you do get more rippling, and it's ideal to have a bit more soft tissue coverage, whether that's ADM or thicker mastectomy flaps, to be able to have that option. So although it may feel a little bit better to not have an implant under the muscle, so maybe you don't get animation deformity that I showed, the trade-off is a bit of that aesthetic limitation sometimes we can see with regards to wrinkling or rippling. But as we also have addressed, there's numerous ways we sort of revise or do other surgeries in breast reconstruction. It's not always a one-stage operation. So things like fat grafting we can use as an adjunct to improve some of those aesthetic outcomes, especially as it relates to implants that are placed above the muscle. A question with regards to DF flaps. With regards to the bulges or hernias that may come post abdominal autologous reconstruction, if there's anything that can be done surgically about these for people who are post-op. Dr. Zong, do you want to maybe answer some of that?
Happy to. So we do know that unfortunately, when we use tissue from the abdomen, bulges can occur. I would say hernias would be quite rare, but bulges are more common. I think probably we say in the literature is around 10% bulge rate after whether it's a DF flap or even a tram flap or a muscle sparing tram. So it really depends on the severity of the bulge. So sometimes women will have a bulge and we recognize it as a bulge, but it's quite asymptomatic for the patient. So if it's asymptomatic, does not cause any functional limitations for the patient, then we can just observe it and make sure it doesn't get worse. And if the bulge presents as a functional impairment for the patient, that's when we should have a discussion about whether or not they choose to have it repaired. So in order to fix a bulge, unfortunately, there's just no conservative way of doing that. You are looking at additional surgery to repair the bulge. Now, at my hospital, I do repair the bulge, but I always do it in conjunction with one of my general surgeons who I work with. Even though we are familiar with the layers of the abdomen, I would say that the general surgeons are probably even more familiar with the abdomen. I'm in a meeting. Sorry. So it's time to go to bed. It's after 9. It's time to go to bed. Stay in bed. It's 9:20. I'm sorry. So I would say then in that case, the bulge will need to be repaired. And then we would talk to the patient about the process and as well as what's required in the recovery. Sorry about that brief.
It's okay. Okay, moving on. That was great. Thank you. I think that's actually a really great explanation of something that doesn't happen that often, but when it does happen, we are able to address it and have many options. A question about the autologous reconstruction DF flaps with regards to healing and recovery time. So Dr. Isaac, maybe you can answer this question with regards to numbers of surgeries may be required, recovery time and healing, and a question about whether or not you have to pay for it.
Absolutely. So I would say the recovery really depends. So you do this operation, or I do for women that are 25 to 75. It's a huge range. And a lot of the recovery can extend beyond what's expected. So an average recovery would be about 6 weeks, which is what we would like to allow everything on the abdominal wall to heal with a firm scar to try and minimize any hernias or bulges. So this is specifically for the DF reconstruction. For the other tissue-based reconstructions that I discussed, it's also an average of about 6 weeks. So the area we take the tissue from can heal properly, and we minimize, the risks of fluid building up, the risks of scarring not being adequate. And so I would say on average 6 weeks. But the recovery really depends on the patient's sort of demands of their own body. So some patients, want to hike mountains, do extreme sports, and really have aggressive demands of what they'd like to get back to. So if you're a marathon runner, you can expect 6 weeks recovery from your surgery, but then maybe up to 3 months to get back to where you were before. And many of my patients that I ask that are very active will tell me that, after about 3 months, I felt like I had never had surgery. And some of my younger patients, 4 weeks later, want to go back to work. And they say, well, I feel great. I feel capable. And I say, well, you need to wait the 6 weeks to make sure that everything heals appropriately so we don't have any difficulties. So I would say on average 6 weeks, but that can range from 6 weeks to 3 months to get back to what you were doing before. And you'd also asked about sort of the anticipated healing. So there's the healing on the outside, which is the scarring, and then the healing on the inside. So again, 6 weeks as your average. And that's about the overall anticipated recovery. I would say everyone's a little bit different in terms of their cognitive return to function. So if you're thinking about returning to work, you want to make sure that you're off all of the strong pain medications, which can take up to 2 weeks or longer. And then a lot of people are now working from home, and so they will go back after 2 weeks, but I do recommend at least 6 weeks of recovery.
And the breast reconstruction across all provinces is covered under the provincial healthcare
Oh,
systems
yeah,
too.
and I'm
So
sorry to see that
no,
didn't come
yeah,
up. That's very
yeah.
sad.
And you're in
I have had
BC
that.
and same.
Yeah, so it's definitely covered, and all of the revision surgeries after are obviously covered because it's all part of the breast reconstructive services.
Yeah, and that's a really important point because Dr. Isaac's in BC, the rest of us are in Ontario, and those first stage surgeries are covered, and the number of procedures it gets for nipple reconstruction or breast mound revisions or the balancing surgeries on the other side, they are all covered in our healthcare system, which is a really great thing that we have in Canada, obviously. Okay, a question with regards to patients who have undergone their initial surgery and feel maybe they may be interested in revision surgery, but perhaps seeking a second opinion and wondering how to navigate that. Dr. Brown, as the founder of Broad Day, do you want to maybe comment on some of your experiences with that?
Yeah, I mean, first of all, it's a very reasonable question, and it's very important and reasonable for patients to advocate for themselves. I think if there is some concern or question about your outcome, seeking out another opinion is a very reasonable thing. It doesn't mean something was done wrong, but often having another set of eyes look at something, you can get a different approach, a different opinion. You can sometimes take that opinion back to your original surgeon and discuss that, which is something I often advocate for. So I don't think a person should be afraid or uncomfortable about looking elsewhere to find out an assessment of what's been done for them and a suggestion of what might be able to be done further. How do you navigate that? Hopefully through your family physician. That's a good place to start. Don't be afraid to speak to your surgeon. I mean, all of us, I think, understand that we try our best. We're not certainly perfect, and there are times when you've tried your hardest and you can't obtain a result that maybe is as optimal as a patient is hoping for. If a patient were to ask for a suggestion of someone else they could go see to get another opinion, often a surgeon is very comfortable being able to try to navigate for that for the patient. So we try not to take things too personally and recognize that the only opinion that matters in all of this generally is the patient's.
Yeah, I think we would all agree with that certainly we do try as plastic reconstructive surgeons to work together a little bit for the best outcome for patients. So certainly I've sent people to other surgeons for second opinions and vice versa. And I think if you have a good rapport with your surgeon, never be afraid to start there, definitely. A question from a patient who is undergoing surgery and then likely is going to have radiation afterwards and is having implants, and curious about in real time now the radiation effect with their current implants that they can expect. Dr. Martu, do you want to speak a little bit about this?
My audio, here we are. Sorry, so the patient is going to have surgery and is anticipated to have radiation. After, and the plan is for implant-based reconstruction?
It appears actually the patient, sorry, let me clarify, has implants, is going to have surgery and wondering about the radiation on the current implants. So it seems not about to have reconstruction at this time, but I think a second part of the question is if they were to, with implants in, have reconstruction, what options might be available?
Right.
So sort of two-part.
Yes, I mean, like I said in the talk, radiation, whenever there would be talk about radiation, there'd be no talk about reconstruction. That definitely has changed with how things have evolved in terms of techniques and radiation approaches. So if a patient has implants already and she's going to undergo a lumpectomy procedure and then she's going to get radiation, there's definitely going to be some effect of the radiation on the implants that she has. And I hope I'm understanding this correctly. As I mentioned, typically radiation will have the tendency to scar tissue around the implant, whether it's the capsule, whether it's the muscle or the skin and the fat. Things can become thinner, more susceptible to infection, dehiscence, and problems. So the patient needs to be aware that there can be issues with radiating current implants that are in place, especially if they're under the muscle. And I would assume that they're under the muscle. But if the patient's surgery will involve removing the implants that she has and potentially placing new implants as part of a reconstruction, then again, it's all about discussing what would be best for the patient. So if the patient has, we talk to the patients about flap options being better options in terms of withstanding radiation, but that's not something the patient wants to discuss, then you can definitely have implants and have radiation, but you need to understand that there are risks potentially with that. And again, depending on where the implant is placed, there is some early data to show that placing it above the muscle may actually be more beneficial, but again, there's no strong data right now. But those are things that can be discussed with the surgeon and decide what's best for the patient. Obviously, intraoperatively, we look at the thickness of the skin, we look at the perfusion and the blood supply. So all those are factors that will help us make the best decision about where to place the implant, and then warn the patient about the possible complications and how we would manage those if they were to happen. Simple things like tightening and capsular contracture, we can release the capsule, exchange the implant, do some fat grafting, but obviously a bit more serious complications, we may need to convert with a flap, a combination of implant with a flap, or just convert to flap completely. I hope that helped.
That was great. Thank you. Somebody who wants to know so a couple questions about delayed breast reconstruction. So how long do you wait after your mastectomy to proceed with reconstruction? So not immediate, but delayed reconstruction. Does anybody want to answer that one?
Radiation or no radiation?
It's not clear, so maybe we can divide it into those two categories.
I wouldn't mind taking that. So delayed reconstruction, if you haven't had any history of radiation, you can, as depending on the type of cancer that there was, sometimes more aggressive cancers, surgical oncologists and oncology teams tend to recommend that patients wait a year or two to make sure that they've healed well, there's no issues. But you can certainly start the discussion with a reconstructive surgeon at any point after you've healed and all your adjuvant treatments are complete. If you've had radiation as part of your treatment for the breast cancer, we tend to recommend that a minimum time of 6 months, and everyone's a bit different in their timing. I tend to say minimum of 6 months, and then usually 9 to 12 months before we undergo put the patient through surgery. But again, a discussion can be started earlier, discussing the options, what would be best for the patient. But we do want to see how the tissues settle before we make a decision.
And there's a question as well about a bit of, again, that kind of navigating referral processes and timing. So specifically with regards to, I've just finished radiation and when can I book in for the reconstruction opinion? And I'd be curious as to other people's thoughts on this. I mean, personally, I keep it a very wide open door. So if somebody has just finished radiation, even if we're sort of looking at a 9 to 12 month window until we would reconstruct in a delayed fashion, I am happy to see patients and start the process of discussion, because I think it's nice for patients to start to get all the information they're hearing about tonight with regards to options. It doesn't mean we're running to surgery yet, but at least we're starting to think about how the tissues are doing with radiation and starting to get the discussion going. But it doesn't mean the reconstructive plan's necessarily made until closer to the date. But with regards to actually getting that referral appointment, maybe everybody can weigh in on sort of, do they have a wait time to even start the discussion after somebody's had radiation therapy?
Well, I mean, I'll state that I would see someone as early as we possibly could. There's going to be some appropriate lag time of waiting to safely do reconstruction after radiation's occurred. But in most of our provinces, there's a bit of a wait time anyways. And so getting somebody information as quickly as possible. Sometimes there's some things that you can even do, I think, to help to recommend to patients to modify and manage their skin envelope that's been radiated, and how to try to maybe even prepare it and make it as healthy as it can be for eventual reconstruction is something reasonable. Oops, the lights went off in the room, I'm sorry. I think there can sometimes be conversations around lifestyle management, weight management, healthy lifestyle, becoming as good a candidate as you can for reconstruction. So I think the earliest that we can see someone, the better. I don't think there's a need to wait.
I completely agree with Dr. Brown. And I think also to the point of what Dr. Martu spoke about in her presentation, which is that radiation changes can evolve over time. For me, I see patients as, I don't have any requirements where they have to wait 6 months after radiation before they see me. I'm interested to see how their skin envelope is immediately, even after radiation sometimes, and I follow along to see how it evolves. And I completely agree with Dr. Brown. I think that there are measures that you can recommend to the patient in the interim time when they're waiting. Sometimes I do think patients can benefit a great deal from, massage therapy, lymphedema therapy, and things like that. So I'll recommend that to them earlier. And for some other patients who may be interested in autologous tissue, I will also have a discussion with them to educate them before about what to expect after surgery, and maybe some of the kind of pre-surgical things they can do to condition themselves better prior to surgery. So for patients that are undergoing delayed reconstruction, I think you can use that time in between to their advantage.
Yeah, I completely agree with the panelists and everything that's been mentioned to optimize. And the one last thing that I've seen quite commonly is contracture of the shoulder joint or difficulty with the range of motion after radiation. And so that's something that we're quite aggressive with our physiotherapists to ensure that they really restore the range of motion of their arm. Because the last thing we want to do is, worsen that range of motion, put them into a condition where they're worse off than they were when they come to us. And just like Dr. Zonk said, it is the perfect opportunity to optimize everything about yourself, including, how well informed you are and how prepared you are, both physically and emotionally.
Okay, thank you, everyone. A question with regards to different types of autologous reconstruction, so not just from the abdomen, but the fact that it was mentioned that the abdominal reconstruction better withstands the effect of radiation therapy, and how does that compare to tissues or flaps from other areas of the body? I don't know, Dr. Martu, if you want to mention your thoughts on that.
Yeah, I'm not sure whether I passed the message that specifically the abdomen does better with radiation. Any flap tissue would do better with withstand radiation. So if I gave that impression, I apologize. So in general, options that involve tissue from the patient would do better with radiation, whether it's from the abdomen or other parts. Obviously, fat from the abdomen is a bit softer than other parts of the body, but in general, tissue does a bit better. But again, they're not invulnerable to radiation effects. But no matter where they're from, they would be susceptible to issues like fat necrosis, contour deformities, shrinkage of the volume, all of those things.
An interesting question about Dieppe flap reconstruction. So Dr. Isaac, I'll throw this one to you, but the first part is if there's a higher risk of doing Dieppe reconstruction on the left side where the heart is, and then a question about whether or not the fibrotic tissue, so I'm assuming it's post radiation therapy, is removed before the Dieppe is applied. So these are a little bit more detailed stuff, but I think very interesting for patients to know as well.
Yeah, I would say from a patient standpoint, it's no different to you. From a surgeon standpoint, technically it can be a bit more mobile, so things can be a bit more hyperdynamic, meaning during the surgery it can be a little technically more difficult, but usually not. Listening for the pulsations after it can be a bit more challenging, but we've managed our way around that. So overall, no, I would say that it's not more difficult. Also, technically speaking, sometimes the vessels can separate and be different sizes on the right compared to the left. But overall, there is really no major difference to us, and we're technically able to do it. With respect to removing the fibrotic tissue, so if you have a lot of scar after radiation, that will maybe impact the skin paddle or how the scar looks. So how much of your native breast tissue we keep and how much we have to remove because it's fibrotic or scarred and just will not expand, and your abdominal tissue, your gluteal tissue, whatever we're using, is actually softer and more pliable and would give you a better aesthetic result. So the fibrotic tissue, if it's really scarred and would not be good in your reconstruction at the end, it may be removed, and that means the skin. And then deep to the skin, so scar that's on top of the muscle, scar that's around your ribs or cartilage, that we deal with as well. And so it doesn't necessarily need to be removed. I hope that answered your question.
Another one with regards to the technical part of a DF flap, or at least a free flap. Is there any other option other than taking a piece of the rib to access the vessels for reconnecting? Somebody who doesn't feel so comfortable with that part of the operation, perhaps we can speak a little bit about the risks of that and what other alternatives there are for the vessel access, or how else we can do free flap surgery from the donor part. Dr. Zone or Dr. Isaac, do either of you guys want to comment on that?
So I would say that removal, it does sound scary. I totally understand that we're removing part of your rib, but just keeping in mind that when I have this discussion with my patients, I showed them it's a very small segment that we remove, and it's not the bony part of the rib that we generally think of. It's really kind of the softer cartilaginous part. It is tiny. We remove about 2 centimeter segment. It does not cause any instability. Now, what it may cause sometimes is pain in that region. And sometimes, depending on how prominent your ribs are, it can leave a little bit of a concavity there. So I would say that those would be the 2 more common side effects from removing that small segment of the rib cartilage. If you feel strongly that you don't want your rib cartilage to be violated, we do have other options. Before we started doing our vessel hookup in the chest, we used to always actually go under the armpit. So there are vessels that we can access there. Now, the downside to accessing vessels in the armpit are if you have had lymph nodes removed in the past, I do think it may increase your risk of lymphedema, because we're digging around where the vessels and the lymph nodes are, where they reside. And probably I would say the biggest downside to using vessels in your armpit area is that if we do use the thoracodorsal vessel, which is the most common vessel we use in the armpit, then it really precludes you from being able to use the latissimus dorsi muscle for a bailout if you need to have that down the road. So I have that serious discussion with patients. And I would say most of us that do DF flaps, we're very, very comfortable with removing that small cartilage from the chest. And I know it sounds scary, but I think after a thorough discussion with the patient, they can come to realize that it's like what Dr. Isaac said. It's a technical detail that I think does give better reliability to the success of the surgery, and it doesn't leave the patients with a lot of morbidity in the end.
I think that's a great explanation for a very technical point that sometimes we don't get too much into with patients, but it's nice to have clarification for sure. A great question about general guidelines with subpectoral implants in athletes, and whether or not chest exercises need to be avoided completely, and consequences of doing them. I don't mind answering this. I'm happy to hear what other people in the panel think as well, especially because for so long we did breast reconstruction pretty much only under the muscle. So in general, I would say that most patients are able to get back to all types of exercise. And that's later once you've recovered from surgery. So that can be anywhere from sort of 4 to 12 months, depending how people heal with regards to getting back to like heavy fitness activities. And then in my experience, certainly I don't tell patients they have to avoid chest exercises, but I will say there are some athletes that don't love the feel from that animation and doing pec related exercise. So whether that's push-ups or chest presses, and maybe they avoid doing them. And then I have a whole series of patients that have no problems at all doing all those activities. So I think it's a bit of listen to your body. I think that patients who develop enough capsule around their implant, so enough scar tissue to really hold the implant in place, they may not get as much of that animation from the pec muscle moving, so it doesn't distort their implant as much. It doesn't bother them as much when they're doing their exercises. And then there may be patients who have an implant that's moving around quite a bit in that breast pocket, and the pec muscle contracting is almost adding to that a bit, and they may choose to avoid those exercises a bit more. But certainly there isn't a guideline to say you can't do pec exercises, you can't do certain activities. Once healed, really it's return to all function, see how you feel. And if you need to alter a few things from a fitness regime, maybe, but certainly from a lifestyle perspective, pretty much anything goes. I'm curious what other people's thoughts are, if anyone wants to add anything to that question.
Well, I think that's very well answered, and I agree with everything that you just said. It's a constant challenge trying to figure out the benefits of being either above the muscle or behind the muscle. And it's a bit different whether we're talking about implants that are being used, I think, for reconstructive surgery rather than for perhaps aesthetic augmentation in women who still have a natural breast there. My experience is that in women who are having implants for reconstruction, where the breast has been removed, but there's generally some scarring and maturity of the space around the implant, that implant sliding out of position when they're under the muscle is much less common than we see in perhaps a cosmetic breast augmentation. But the flip side is that the animation, and for people that aren't quite sure what that means, the sort of visibility of the skin perhaps moving a little bit when the muscle contracts is more noticeable, I think, in our reconstruction patients because there is no breast there to protect everything. There's the skin and the breast has been removed, and then there's the muscle and an implant underneath it. So I think it's a real issue, and it's one that we all see with our patients. We know that the breast develops on top of the muscle, and so the ideal place to try to reconstruct it is on top of the muscle, and that's why many of us over the years are migrating to try to get better approaches for placing an implant above the muscle. As you mentioned earlier, Mary Helen, it's a huge trade-off in the concern of rippling and visibility, and so I think we continue to evolve with our approach. I'm interested to know from the panel, it might be an interesting question, that in all of your implant-based reconstructions that you do today, what percentage would you say you're placing the implant on top of the muscle versus behind the muscle? I can tell you, if you asked me 6 years ago, it was 100% underneath the muscle, and maybe you're all similar. Today, I might be placing it 60% of the time on top of the muscle. And so that's changed quite a bit. I'd be interested to hear what the rest of you are doing.
I can say in the immediate cases above the muscle, I'm probably 90% above the muscle now. As long as the mastectomy flaps are good enough to offer an aesthetically pleasing result, I'll go above the muscle. In delayed, I still go submuscular if I'm doing a tissue expansion though.
I would say same thing. I'm very lucky to work with 3 general surgeons that leave me excellent flaps. So as soon as prepectoral reconstruction was entering the discussion, I switched. So every time I'm happy with my flaps and the perfusion and the thickness, I always prefer to go above the muscle, whether it's delayed or immediate. So I would say if it's not 90, like in the immediates, most like Mary Helen, I would do 90% based on the flaps. In the delayed, again, if I have a nice thick, I'll just go thick flap, then I will just stay above the muscle whenever I can.
That's very interesting. I think at our center, about 3/4 of what we do, or at least in my practice, I can't speak to my partners, they may have a bit of a different approach, but about 3/4 of what I do for immediate implant-based reconstruction is submuscular. I think only about 1/4 of the time I feel comfortable going above the muscle, comfortable enough that the mastectomy flap is robust enough to tolerate a tissue expander or implant underneath. So I'm also interested to find out from the panelists, what percentage of your practice do you think where you're using a tissue expander versus going directly to an implant?
These are all such great questions. So
Yeah.
the first one, the under the muscle versus over, I would agree sort of more with Dr. Zong and Dr. Brown that it's probably in my practice about 75% is on top of the muscle. And the 25% that I'm still doing below the muscle is really when someone has advanced disease. And I do not want to in any way compromise their treatments with radiation or chemo after. And if the skin does not look perfect, I will put it under the muscle and use a tissue expander. So I would say not all, but majority are being done on top of the muscle. And if there's any question about the blood flow to the skin, then I will definitely put it under the muscle. And I would say to Dr. Zong's question, I would say about 90% of the time I'm putting in tissue expanders. And that is really because I am very cautious about delaying any type of treatments after. And I think with putting a tissue expander first, I'm able to, more predictably expand and not potentially compromise their skin after. So I would say, that's sort of a very hard question to answer in a big panel like this, but the majority of the time I use a tissue expander, and if someone's very motivated and they want to use an implant right away, I will try my very best.
And do you put that expander above the muscle then for those cases?
Yeah.
But I think one of the most important themes that we just heard was that we must respect the disease and the process that the patient is undergoing for treatment of their cancer, if in fact cancer is present. And as reconstructive surgeons, put a priority in not doing anything that could impact any ongoing cancer care. And so I agree completely with what Dr. Isaac is suggesting, that in patients who maybe are not preventative mastectomies or not precancerous disease patients, that where adjuvant therapies and chemotherapy and radiation may be more likely to occur post-surgery, that we should put every priority on ensuring that we perform a reconstruction that is the most likely to heal with the least number of complications, so a patient can get on with their adjuvant therapy as a priority. And I know that we all tend to do that fairly routinely. So it probably depends a lot on your patient population. I know at Women's College, we have a large number of patients who are risk-reducing mastectomies or very early stage disease. And I would say in those patients, the vast majority of the reconstruction that we do is implant directly. And in patients who perhaps are in the midst of their adjuvant therapies, we're more likely to put a tissue expander. I don't know if that's everybody else's experience or not.
I mean, as far as the question about expander versus implant, again, it's really based on the patient's, again, overall cancer treatment plan, but also the perfusion in the skin. If I have any concerns at all, I would agree with Dr. Brown, Dr. Isaac. I tend to sort of be conservative. If I'm happy with the flaps and I think I won't have issues with complications and delaying in the adjuvant treatments, I'll go ahead with an implant. But if I have any concerns at all, and I'm, I always say to the patient, the consent is direct to implant with ADM plus minus expander. The decision is made intraoperatively, they need to be prepared. So then I will put the expander. I'd say, more implant than expander, but I still use expanders in my practice.
Yeah, I agree with everyone. Same thing. So for the earlier stage cancers and definitely most of the prophylactics, as long as we're sticking with around the same or similar size of breast, I'll go direct to implant, typically above the muscle. But as we move into more advanced disease or need for adjuvant therapies, that may dictate use of a tissue expander. I also use tissue expanders more in patients in some of the cases that are presented tonight with regards to unilateral or one-sided reconstruction. If you're going to be doing something to the opposite breast, or maybe need a little bit more stretch of skin to do both side augmentation and an implant-based reconstruction. So one reconstruction with an implant that's a bit bigger than they first had, and then a small augmentation on the other breast to balance. Sometimes I'll be using tissue expanders in those scenarios. And then another comment with regards to, again, a good point from Dr. Isaac, when we think about the adjuvant therapies and the fact that, as Dr. Brown mentioned, the most important thing is breast cancer care. So from the oncology perspective, some of this may not happen in immediate fashion, depending on someone's stage of cancer or where they're at or their treatment regimen. But one area where I will divert to below the muscle is when patients have deeper tumors or tumors that may be very close to what we call the posterior aspect of the breast or the muscle. And that's for monitoring post-operatively for any chance of recurrence. If there's any chance we may get a deeper recurrence, then it's nicer to have the muscle on top of the implant as opposed to below the implant. Okay, so a great question about lymphedema and whether or not a patient with lymphedema can still be a candidate for either a lat dorsi, latissimus dorsi flap, or a DIEP flap, and how that may impact their result.
Great question. I can start if you'd like, Dr. Zong.
Yeah.
So I would tell this patient that, you know, in many provinces across Canada, there are now great programs that are coming up where there can be some lymphedema treatment in addition to your reconstruction. Overall, will lymphedema complicate your reconstruction? Yes, in that you have two diagnoses. You have the delayed reconstruction need, and you have the attempt to reconstruct the lymphatic system if possible. So overall, it's more complicated. Is it possible? Yes. I would say that, you know, it's sort of a whole other discussion where lymph nodes can be transferred with the tissue, or lymphatic channels can be connected to try and improve your lymphedema. But again, this is not 100% in all patients. I would say it is ongoing research to know which is best for you, and definitely worth a discussion. So in short, it will make it more complicated, but you could have improvement in your lymphedema at the same time as your reconstruction. Or you may have no change in your lymphedema, or at worst, it could worsen depending on what options are chosen for you. Dr. Song, anything to add to that?
So I would say that if you do have pre-existing lymphedema and you came to see us about breast reconstruction, I would separate the two issues. And I would say that if you were a candidate for either a DIEP flap or a latissimus dorsi flap, the safer option would be using the DIEP flap. And I would make sure I hook up the blood vessels, like we discussed before, to your internal mammary, so outside of the armpit area. Because I feel that if you're doing your latissimus dorsi and you're tunneling it from the back to the front, you're creating extra trauma in the area that's already traumatized and already suffering from lymphedema. And so I think that's how I would approach somebody who came to see me, let's say, for breast reconstruction. But if someone's goal was to alleviate their lymphedema, then I would say that that would be a separate discussion about lymphedema restoration. And it would, again, just really depend on if you had mild versus moderate versus severe lymphedema. And there are current therapies, conservative therapies, as well as surgical therapies that are present. And people in, and there are people who have a special interest in this. And so, for example, at my hospital, my partner, Dr. Haycow, does this, and there's a program dedicated to this, which is very, very good. You know, they evaluate patients with measurements before and after surgery, and make sure you're set up with the necessary support programs that go along with the surgery itself.
Great, thank you very much. I'm just looking at the time, it's 9:55, and I think we're ending at 9:55, aren't we? Yes, sorry. I did not finish that. Sorry. Are we still on? Am I allowed to finish our session? Thank everybody.
We're still on, Dr. Mahoney. You're welcome
Okay.
to continue as long as you'd like.
Yeah, sure. Okay. I just want to thank, sorry, I know we didn't get to all the questions. I did lose track of time. I apologize. But I thank everybody. I'm going to see if I can respond to some of these questions quickly by typing. And I thank everybody from the panel for answering everything. I do have to advise everybody that since we didn't get to all your questions, please reach out to the Cancer Information Helpline. And if you need any help finding resources to visit the Community Services Locator, And if you want to continue any of these discussions, you can visit cancerconnection.ca. And I will type some answers to some of these questions so people can feel that they got enough of their questions answered. And of course, there will be many other opportunities through these adjunctive sessions here that you can enter to ask some more questions. So thank you, everybody. Thank you to the panelists.
Thank you. Thank you very much.
Thank you. Good night.
Thank you, Fran.
Dr. Mahaney, if you'd like, I can leave the link live for a while longer so you can type some answers.
Yeah, can you leave it live for a few minutes and I'll just type some answers back and then I'll just log
Sure
out.
thing.
Okay,
Yeah.
thank you.
Thank you. Have a great night, everyone.
Thank you.
Thank you, Mary Ellen. I'm going to go join the closing session. Thank you so
Okay,
much.
thanks a lot. Thank you.
Thanks, everyone. It was great seeing you.